Good morning. In recognition of the time, I am Dr. Suzanne Feedham, Nursing Research Consultant at Children's National, and it is my privilege to welcome you to the second Nursing Research Day at Children's. Today culminates an exciting week of dissemination of research findings at Children's. I bring greetings from Dr. Hines, who is on travel this week, and I would like to commend Eileen Ng and the Planning Committee for this very exciting day and all the work that has gone into the day. I'd also like to welcome, we have guests from Baltimore, Fredericksburg, Philadelphia, Richmond, students, faculty from Georgetown, Catholic University. The WebEx is open, and so we expect that there are people watching from Tech Hill and other of our ROCs. So this is an exciting opportunity for everyone to hear today. It is a privilege. I thought I was welcoming Dr. Frink back to Children's, but then I found out while I was out of town, she was back here on Wednesday on a special site visit with the Bear Institute Innovation Center. So welcome back today, even though you were here already this week. And she had an opportunity to meet the folks that are on her response panel. Dr. Frink is a national leader in health IT. As Vice President and Chief Nursing Information Officer at MedStar Health System, she is responsible for strategic operational nursing leadership. Now, this is a long list. In the development, deployment, re-engineering, optimization, and integration of clinical information systems to support clinicians and patient care, including she leads the nursing and the adoption of technology-enabled process change that maximizes patient safety, quality of care, operational efficiency. Obviously, this requires someone who really is an outstanding systems person and works well across disciplines. Dr. Frink is a scholar with invited presentations nationally and internationally and publications in journals and textbooks on topics specific to healthcare policy, delivery, and clinical informatics. The point of all of these publications are to advance the translation of research to practice and the application of health IT. She is published on articles such as Information Technology, a Foundation and Enabler for Translation of Evidence to Practice. So that's, you'll see and hear more of that in her talk today. While at Children's, she co-authored articles on a management database for staffing analysis and randomized controlled trials. I have observed Dr. Frink and have learned that she is really an outstanding systems thinker, a consistent and very strong avid advocate for nurses, and she has been instrumental in assuring that electronic health record systems enable nurses to provide effective, safe, quality care. For example, last fall, in discussions with clinical nurses at Georgetown, a MedStar hospital, unsolicited, two nurses made points to tell me, as I was standing by the cows in the hallway, that two nurses, without my even saying who I was or that I knew Dr. Frink, went on to exclaim how they were so pleased with the upgrades and changes in the IT system at Georgetown, that the changes had improved their communication with the physicians and other disciplines, that they were able to receive real-time information for clinical decision-making. And I think you will hear through her presentation today some of these attributes. Dr. Frink was a special expert in nursing systems at the National Institute for Nursing Research at NIH, and she is currently a lecturer and associate faculty at the Johns Hopkins School of Nursing and was formerly in this type of a role at the University of School of Nursing in Pennsylvania. So after Dr. Frink, we have a response panel, and I will introduce them when she finishes her presentation. Welcome, and thank you all for coming.
Good morning. So good to be here with you all at Children's. It is indeed coming home. Thank you very much, Dr. Feedham, for the introduction. And it is wonderful to see familiar faces and meet new faces, and just to catch the energy from you all this morning in the brief coffee hour of the kinds of work that you're doing and what you're engaged in, and certainly the productivity of the poster session downstairs is witness to that as well. So I want to share a couple of personal comments because this is home. So I hope that you will bear with me on that. Children's was very formative in my professional development. The mentoring environment that was here when I was a nurse educator and then involved in research was just very powerful under Dr. Feedham's leadership, but it was also the entire culture. So not only did I learn tremendously, of course, about the care of children and families, but I learned about the importance of health policy and what an influence that had on the ability to deliver care for communities of children and families. And the research environment and how integrated the research was within the practice of care was just very powerful, to the point that I became motivated after being not motivated to pursue doctoral study, and did that while I was here at Children's. So very powerful influence that was present in nursing and in the provider community here that really enriched my own development and moving ahead in doctoral work. So I'd also bring you very warm greetings from MedStar Health. We are your neighbors, of course, across the quad with two of our facilities, the National Rehab and Washington Hospital Center, and I understand we're connected by a tunnel as well. In addition, we have 10 hospitals in total and a number of healthcare-related businesses. A VNA right now that actually represents the inflection point of what we're seeing in healthcare policy, and that is that we have the same number of patients, inpatient, across 10 hospitals on a daily basis as we do in the VNA caseload per day. So that tells you what's happening in the larger arena and the shift on the ACOs. In terms of health information technology, I tell you that we have 8,400 nurses and 8,000 physicians as both affiliated and employed. And so when we're talking about implementation of systems and adoption and optimization, there's an entire culture of caregivers that need to be engaged and helping in the design and review to make that happen. So I wanted to highlight the experience we had here on Wednesday with a delegation from neonatology and the Bayer Institute here at Children's and Dr. Jacobs and leadership there that shared with us your progress and outcomes in regard to particularly neonatal health information technology, and then we were able to tour both the NICU and the cardiac intensive care areas. And I want to thank the participants, but on behalf of all of you, because what was communicated to our team was this wonderfully strong culture and how engaged everyone is in the outcomes that are possible with health information technology. So look forward to future collaborations and being able to share progress across our institutions. So the planning team for today's event, and I worked out exactly how we were going to approach the topic. It's a little large to talk about clinical research, quality outcomes, and enablement by health information technology. So the objectives of addressing across my remarks are discuss the emerging relationships between those areas and then be able to describe three aspects of evidence-based practice and practice-based evidence. So as I begin, I want to talk to you a little bit about from the context from which I'm speaking and also give you some definitions. The talk this morning will be divided into essentially three areas. One is key processes that enable movement of evidence-based practice through technology into practice, strategic relationships that are critical, and critical roles in informatics. So I'm taking the broad view this morning. If you say clinical research and we went around the room, we would probably have a number of different definitions. For my remarks, the context is the biomedical research enterprise. I'm not limiting comments. Also inclusive of that, clinical knowledge management systems and evidence of translation to practice. In terms of quality outcomes, again, in the eye of the beholder, outcomes can be very narrowly defined to the individual patient and family, maybe to the health system, population health, and actually also included in local and national health and health system metrics across the country and actually internationally. So important when you're thinking about these areas is to set your boundaries and understand what your scope is related to the research and what level of outcomes are you talking about. A couple of definitions. Health informatics is a growing field. We talk a lot about medical informatics or nursing informatics, but there are a number of disciplines involved in health informatics, and each of these that are mentioned in the left-hand column are developing their own discipline and their own standards of practice. So for a grounding definition, health informatics is the interdisciplinary study of design, development, adoption, and application of IT-based innovations in healthcare services, delivery, management, and planning. And then from Gardner and Overidge et al., published in JAMIA in 2009, clinical informaticians transform healthcare by analyzing, designing, implementing, and evaluating information and communication systems, enhancing individual and population health outcomes, improving patient care, and strengthening the clinician-patient relationship. So that's the context from which I'm speaking this morning. In addition, how do clinical informaticians use the information and their knowledge to be able to bring value not only to clinicians at the bedside or in the community, but also to patients and families, and you see the continued definition there. So in terms of the large vision, why do we all do what we do? I like to think that we are all part of the continuous learning healthcare system that is value-driven and science-driven. So I'm using as a reference here the IOM's work on learning healthcare systems. There are a number of publications that they've had over the past several years regarding learning healthcare organizations. Key to that are science, informatics, incentives, and culture being aligned for continuous improvement and innovation. That's care processes, patients, families, and active participants. Very important concept, active participation of patients and families, and new knowledge captured as an integral part of the care experience. So for years we've talked about getting the evidence into practice, and now we are talking about not only that, but how are we getting the evidence from practice. IOM goal by the year 2020, not that far away, 90% of clinical decisions will be supported by accurate, timely, and up-to-date clinical information and will reflect the best available evidence. That is a powerful goal. So if we all think we might be underemployed in the next 5 years, probably not going to happen. This is a huge mission and very exciting one to be a part of a continuous learning organization. So let's start with talking about introducing the evidence into the process of care through electronic health records. And when I'm talking about evidence in this context, I'm talking about the evidence that is coming from the science side, from research, whether that be randomized controlled trial, other types of outcomes, other types of studies, which we'll review in a minute. So evidence-based clinician provider order entry, clinical decision support. I know that I have seen this in your system. You have a number of clinical decision support programs. Here are some examples of things that are represented here. And you'll see that there's a bit of a hierarchy. Talking about an active reminder, an alert, or a guardrail is a different level of informatics than having a risk identification program that's based on algorithms that runs in the background. So saying clinical decision support is not just a unitary concept. It really covers a broad range of application areas. Evidence-based interdisciplinary plans of care. Nursing has a great deal of work to continue to do in this area. It's difficult translation into a computerized environment. And the continual theme that I hear and that I also sense myself as I look at our work is that we are still not able to really tell the story of the patient through the interdisciplinary care plan. We're getting there and we're improving, and we have the goals clearly identified and you can see the progress, but it's still in a data to information, but not a story yet to get to the knowledge and wisdom. So I look forward to collaborating with you all in this area and continued development. Evidence-based, medication safety, huge area. We could talk about this, for an entire day. It includes not only the clinical decision support within the health record, but also the devices and connectivity of pumps and other methods of administration, and then clinical knowledge management. So how do we get to this point? Following the lead of the framework of implementation science, looking at the strategic decision for change, is where this happens at another level generally than the clinical practice side. It's really a unified strategic decision that has both a clinical agenda and a business financial agenda for an organization or a system. And then there's a tremendous effort, often it can encompass several years sometimes, or sometimes a shorter period of time for system selection and evaluation. And then a strategy and an infrastructure is designed around what that selection process has resulted in, and then the implementation. System adoption, in the best cases, follows, and then evaluation and optimization. The most of the energy, if you will, and focus in an organization is often on the navy blue boxes here, because I call it the bricks and mortar of health IT. It's what's visible, it's what's in your face, it's what costs so much money initially, where you're looking at the contracts and you're coming to an agreement on what your particular strategic plan will be. And then the implementation involves so many resources across the organization to become involved and educated and participating in designing, that's where a lot of the visibility is. The hard work, if you will, begins after the implementation and moves through into system adoption and evaluation. And that work is never done in my assessment, that we continue on in this area. It may involve some going back around the circle a bit and implementing some new software or new applications, but it's continual training, reviewing workflows, and evaluation and reviewing of evidence. It is indeed an ongoing process. And I've just mentioned that is often a challenge in organizations in regard to how you build your staffing and your infrastructure to support health information technology. And there are instances where people will look at what I was describing as bricks and mortar and say, well, once we've finished with the implementation, we can let an entire group of staff move on to something else because there's no more need for that high intensity. It's a different intensity. And that adoption and optimization is really critical, and it requires continued resource. So implementing an enterprise EHR does bring data for decision-making to the point of care. And I've outlined several of ways in which that occurs. Very pleased to see the other day your quality dashboard creation display, very powerful, clearly accomplished through innovation from the Bayer Institute, as well as with the clinicians and clinical informatics staff, and used on the clinical units. very powerful. Integration of point-of-care devices with the EHR, including your biomedical device interfaces, infusion management, continued challenges here across the country in regard to how to manage these and come to a best practice. And then using data that's captured as part of the process of care to be able to support performance improvement and national quality improvement measures. And not just those, the data can be used and captured in the process of care to support a research agenda in clinical studies. Applying evidence to practice doesn't just happen, and behind that application are very large, complex constructs. So I've listed some of those here. The biomedical research enterprise. It is huge. That is where the results come from the science community. But the science community is not simple, and the range of studies is huge. We'll go over the levels of evidence in a minute. That itself, very complex. Then the national quality and patient safety infrastructure, the guidelines for that, the continual movement and progress across the country. National and professional societies also have their own set of practice guidelines that are published across that particular discipline. Health advocacy organization, clinical health information technology infrastructure, health beliefs of patients and families are critical, and often these are not included necessarily in our design and our thinking. We could spend another day talking about our experience in our roles and our lives outside of healthcare and the kind of technology that we and our families use and adopt and how that is changing our lives, and the feedback of the wearable devices and what's happening with that. So how does just that culture in our wider communities affect expectations and possibilities within the healthcare service environment? And then certainly you all know from experiencing workload firsthand that practice patterns of individuals and groups of clinicians can really be affected and affect the outcome of applying evidence to practice. This is a chart included in a chapter that I wrote about translation of evidence to practice and technology as an enabler. But I want to just point out the top level of process there. The biomedical research, all of that brings synthesis of research findings, then the dissemination of research results, and finally the application to practice that in past times, if you will, prior to full-scale EHRs, that practice informed new research, still informs new research, but it also informs what happens through the process of care, where we're then able to evaluate post-care, because of all the data that's available, what really happens in the real world when you apply that. So just a brief word about the study hierarchies. When you are evaluating evidence for practice, the hierarchy of the randomized controlled trials, still the standard, non-randomized trials, longitudinal cohort studies, et cetera, you can see the list there. But understand when you're thinking about evidence that there is a hierarchy and you want to know the quality and the scientific credibility of that evidence. The next level is to think about the synthesis of the research findings. We now have many reports of synthesis, meta-analysis, economic analysis, and guidelines that have all come from a synthesis of these research findings. And the next stage is often where things get difficult, right? The dissemination of the research results. There are challenges in timing. There are challenges in uptake of the data. So when we have the instantaneous social communication through social media of things happening, and then you have research results that can truly affect clinical practice and outcomes for patients and families, and a lag still sometimes of many years. So a real disconnect there in terms of timing, and we all can have a role in improving that. And excuse me, and then finally, clinicians, patients, and consumers uptake. So in some ways, it's very hard to believe today that up until 2004, we really had no national health information infrastructure. In 2004, President Bush appointed Dr. David Brailer as the first national coordinator for HIT, but it was somewhat of an unfunded mandate, and there wasn't a large office, and there wasn't staff, et cetera. But since that time, we all know and have lived through what is happening with the Office of the National Coordinator, and now truly has moved into healthit.gov, and that's the website. And anything you want to know about healthit.gov, you can click on that particular link. Two things I'd like to point out about the Office of the National Coordinator is that there have been two ongoing committees almost since the inception of the early work on design of meaningful use programs. It's the HIT Standards Committee and the HIT Policy Committee. So a particular challenge for nursing, as you all know, is codifying our data in a meaningful way that can be part of the larger informatics lexicon. And I quote here Dr. Sue Bakken from Columbia, components of infrastructure that are essential for evidence-based practice and deriving evidence from practice, standardized terminology, digital sources of evidence, data exchange, standards, informatics processes, and competencies. So we have had a history of, there are 11 nursing taxonomies. They're all relatively new, all within the 20th century development, most since the mid-century. A lot of controversy and energy around the different taxonomies, and they are actually, they have evolved with different levels of granularity in the data, so that if you're familiar with SNOMED, I'm sure most of you are, all of the taxonomies for nursing, the major ones are indeed mapped to SNOMED, but they're not mapped with the same granularity because they don't bring that to the table. We have not had enough of a research base to really support that. So if you're interested in this particular area, I'd recommend the work of Dr. Connie Delaney at the University of Minnesota, who has now set up a center there for the study of the taxonomies. And there is a workshop held every June to bring scholars in from across the country to continue to refine nursing taxonomies and the data exchange standards and the conformity there. Why is this important? One reason is that if you can't codify the data, you will not be able to get the results on the other side, and you will not be able to see what contributions or effects there are in practice of a particular nursing intervention, et cetera. Very important. A particular focus of Dr. Delaney's team now is looking at big data and making sure that nursing data are represented in that. So traditionally, we look to the research results to answer practice questions as one part of our search when we're thinking about evidence. Specific guidelines, evidence hierarchies, and standard methods of inquiry. But what we're seeing with enabling of technology is developing methods of systematic reviews, integrated networks for research, data repositories in clinical care, and big data and predictive analytics. So very, very different developments enabled by technology. We talked a little bit about the evidence coming into practice and the evaluation of that through technology. Now turn a little bit to the generating of knowledge from the practice level. So the real-time harvesting of practice data. There are any number of clinical examples that you all could give from your own experience and your research work, but certainly we're able to look at monitoring the effectiveness of interventions, of particular drugs or treatment strategies longitudinally on patients or on population. So the leveraging here, you can do this within a unit, you can do this within Children's National Health System, and then you can be in a collaborative across the country with other pediatric institutions, leveraging the data in a particular area to look at variation across the country. Rapid diffusing of research evidence through active clinical decision support and knowledge management. So there are large companies in the country that deal with evidence-based practice, production of evidence, the continual review of evidence, and they are, often are part of our partnership networks in being able to keep our practice evidence up to date. And those reviews are continual, and every 6 months to a year, every area of clinical decision support is reviewed for accuracy and timeliness. And then finally, introducing EHR tools supporting efficient clinician workflow and bringing evidence to the point of care. I am sure if I asked you individually about efficient clinician workflow, everyone would have a story. And despite being thoroughly engaged and clinicians being involved in design and development and setting up the forms, if you will, and selecting data elements and reviewing the evidence to make sure you have the right thing, and you get to the time and you do the testing, and then it goes to implementation, and you even mocked the workflow, right, and work with that. But when it goes into practice, some unexpected things can happen as a part of the workflow experience. So this area, although we don't talk about it much from the science side, has human factors, engineering components, workflow components, and it's an area that in the optimization and adoption arena is continual work. Talking about the patient level, moving to a population health level, lots of opportunity now with new networks such as cloud computing and collaboratives, grid technologies, research networks. These support very large-scale research endeavors with national or international data sets and multiple clinical data owners and data archives. An example of this is the biomedical informatics grid that was established by the National Cancer Institute a number of years ago. It has now moved into a new type of technology, but it's a very good example of what a research grid across the country. Participation in learning collaboratives for research and practice, and then new analytic models and using evidence-based algorithms, which you already do here, and certain areas of risk to be able to understand population health. And then the new area, predictive analytics and the use of big data. I don't know about the rest of you, but if a morning has gone by and there hasn't been a communication from some publication or in the news about big data, it will be there in the afternoon. It is a ubiquitously used term right now, ill-defined generally, and it is. You can be talking about Wall Street. You can be talking about other financial areas. You can be talking about big data in healthcare and other areas. So interesting time to see how this will sort out. Brief word about clinical knowledge management. It's really a key component of learning system governance. This does not just happen as a byproduct of the introduction of an electronic health record. It has to be thoughtfully produced. It's part of the governance, and you can see some of the points that I make there. Has to include an inclusive and structured review process, a way to catalog those, and really requires clinical forums for content and process by the people who are the ones who are using the evidence. Again, very important concept is to build an infrastructure to be able to support evidence-based practice, whether you're talking about bringing evidence in or you're talking about harvesting the evidence from practice. Main point I would like to emphasize here, it is circular, as you see, but this is an executive leadership area, I think, to correctly gauge the capacity and capability within the organization to develop this. It's a real challenge. If you overshoot it, you raise expectations, and then it's really difficult to come back from that. Obviously, you don't want to undershoot on the capability side either. You want to know where you are, but you have to be able to set the metric that's appropriate for your organization, and it may take several years and several iterations to get to the point. And you can start small here. Clinical practice partnerships, guidelines, very important to evaluate results, and then use those results in the outcome evaluation to increase your knowledge and improve the practice and feed through the system. So this is cyclical, but I think often there is a tendency to say, well, we built it, people will come, that it'll be adopted, we'll make it better, optimizing it, but really there's quite a sophisticated infrastructure behind that. So a lot of times I get questions about technology, and my bottom line answer generally is the technology is very important, but it's really about the people and it's about the relationships. And that is, it just makes or breaks all of the possibilities for optimization and clinical outcomes. Is the people make it happen, and the consistent relationships make it happen. Now, I realized when I wrote this slide, I was doing so on that title of partnerships with key organizational roles. I left my own role, the NIO, out. It was an oversight, but it was an oversight because I was talking about it as partnerships that are very important for me to be able to do my job. So I had to edit the slide because the NIOs need to be in the list as well. But I can't emphasize enough how important the chief nursing officer, the chief medical officer, the chief medical information officer, vice presidents for quality, and chief information officer are. Whatever the title in the organization or system, these are key relationships, and if they are not working together or in sync in regard to health information technology, there is tremendous risk involved. Now, is there a difference of opinion and you need balance? And absolutely, it has to be a discourse. But the bottom line of what is the strategic plan, how is that plan resourced and then carried out is very, very important. And I have been in organizations where these relationships were stellar, and I've been in organizations where there were some challenges. And there is a fundamental difference in the outcome when you have those kinds of challenges. So just another kind of process or infrastructure piece, clinical practice, automation, and technology, see some of the components there. Then how do you get from that to system learning? How do you get to system outcomes? And then policy and business implication. Another way of looking at the cycle. And I would like to just commend you all for your leadership with the Barra Institute and the work that you have done both prior to the formation of the Institute and since its formation. I think it's really a leading example of both in pediatric care, but also nationally in terms of relationship. So in full disclosure, MedStar Health, give you just a brief background. Within our 10 hospital systems, 7 hospitals have been Cerner clients since about 2008. We are now on a third phase of implementation. We are not where you all are, and you've done tremendous work since 2008. But we have quite a bit of the application running. At the point where we finished our second phase, we had not done ambulatory care, and the organization took a step back because out of a whole piece of work with focus groups on the part of our executive leadership across our enterprise, the most important thing for clinicians was an integrated system. So that meant stepping back and asking the question, where do we want to go, and do we want to make a change, or do we want to continue on the path that we're on? So it was a year-long, another due diligence right after we had finished a huge implementation, and that decision was completed this last fall, and I'm very pleased to say that we continue to be not only Cerner clients, but Cerner partners, and we have a new partnership level of agreement. We actually have shared some staff that you all have appreciated here and are now helping us at MedStar, and we can see the new possibilities. So I would support the fact that this is not just a relationship with a company or a series of companies, regardless of what that health information technology company is. We happen to be talking about Cerner here, but it certainly is true with other vendors as well, that it really has to be a partnership. It cannot be a disjointed process, and it goes on for many years. So it's extremely important to work out those relationships. And I think you have already experienced some of the development and discovery that's coming because you have the kinds of relationships that you do. So what does it take to support evidence-based practice process in the organization enabled by health information technology? So I've put up essentially 3 lenses. So the executive leadership or your practice leadership, you can take the functional viewpoint. What does it take functionally to do this work? And you can see the list of some of the roles that I've put there. And that's the functional view, and it's absolutely required, but it's not all that's required. And I do want to say just for a moment, I want to talk about the application designers, builders, implementers, the analysts. Where do they work? Often removed from an organization, in another building maybe, in another community, in a large system, that would be true. And they work tirelessly on continuing application optimization. They have their own stories of why they do this, and many of them are very compelling stories, just like our patient and family stories. And it means a great deal to them to understand what this work for many hours in a dim-lit room, looking at a computer screen and working with code or whatever, what did that mean? How did that translate into what happened in the clinical environment? So it's another type of relationship that I would encourage, is that the clinicians and the people who are building behind the scenes get to know each other a little bit, at least to communicate back and forth, because it really brings great meaning to the work that they are enabling to happen. Then there's the technical lens, if you will. You need subject matter experts, researchers, content providers, and those might be internal or external, performance improvement teams, and again, knowledge management. And then finally, what does it take to integrate these at the point of care? So workflow optimization, we talked about for a minute, conversion of the captured data. So often, I think across the country, we experience that we work so hard to define the data that are going into the system and to make sure the evidence is there and move it into the system. Getting it out is what? It's a challenge. It's hard. It doesn't come with, here are your 65 canned reports, and here's your exploratory reports. The system development has been very pressed to continue development, meaningful use, and for other reasons on the system side. But being able to draw the thread through, if you will, to get to the outcomes and the evaluation has its own challenges. So again, it's another infrastructure that needs to be thought about so that there's investment available to be able to harvest the results of all of the work there. Just a brief word about clinical informatics roles. One example would be roles for performance improvement and quality outcomes. You can see the various skill sets and areas of behavior that I've put on the grid. Again, it's another part of the infrastructure. And from recent experience, I can tell you if the performance improvement and quality experts in the organization are not at the table on the front end of the design and understand what is going to happen to their work environment because the clinician designed process change, there can be a fair amount of disruption for them and an interruption in the data flow, which affects your quality outcomes. So again, it's another partnership that I think can't be underemphasized, and working hand in hand to be able to have the outcomes in system reporting. word about metrics and outcomes, some of the very practical kinds of thinking that I know you all have already experienced, but with every additional application is worthy of asking is, how are clinicians responding to decision support? And do they find what you've done of value, and how does it change care? So I love the feedback in terms of finding out what's the real. There's the perceived work that you think is really happening, but then there's the work that's really happening. So when you're conducting interviews with staff and just seeing how things are going for them, you learn a tremendous amount. And I one day had a fairly mature person in practice say to me, I know you think these interdisciplinary plans of care are really important, but I'm here to tell you, I know I have to do it, and I check it off at the end of the shift, and it's the last thing I think about. So that was a very wonderfully candid and from a response from a person who had had tremendous clinical experience, and I take that as we have so much to do because there's no value add, and I can tell you the labor on the front end and the practice that it supports, but it's not making a difference in the practice. So what do we do with that? Those kinds of questions. So efficiency, simple things, saving time for whom? Does it have downstream consequences? Sometimes you can put a whole process in place, and the people on the front end of the process, are just ecstatic. It's transformative. It's wonderful, but there's a downstream effect. And 3 other departments had to change their workflow because of what was designed in another area. So again, the synthesis and integration between and among is really important. Do the outcomes make a difference, and for whom and at what level of magnitude? So Dr. Jacobs and I were speaking briefly the other day, and he talked to me about he had come in on a nursing documentation design of the form and the data elements that were being identified, and he had no idea that nurses collected this particular series of data, and it was descriptive data, and he was just amazed. And he said, well, why are you collecting this? And, well, it's because we need to collect this. This is nursing knowledge, and this is nursing data, and it's very important to our practice. So that was an interesting exchange, and the challenge, I think, is that we often do things from we really need to do this, it's important, but if you ask the next level question of what difference do these data make in the outcomes for a patient or family, in quality or in reporting, you can come up short. So I would just ask you to be very thoughtful as you're designing documentation and data elements, and to not go overboard because of the obvious work burden that it creates in the workforce. And again, in transparency, we made this error. We're currently working on critical care in both for all disciplines. We had not implemented critical care. But in our last implementation that ended in 2012, the critical care nurses adopted the data forms of nurses from the med-surg unit. And I probably don't need to tell you what happens, because on the med-surg unit, the time of how often you collect those data elements was extremely different than in the critical care nursing. And it brought people to their knees. They were trying to collect just inordinate amounts of data on an hourly or 2-hourly basis. It was interfering with patient interaction, families. So we were able to introduce a change that helped to relieve some of that burden, and now with the critical care design that we feel that efficiency in the workflow will be fully worked out. It was an unintended consequence, and it happened because people wanted to adopt what was developed. But the care processes and workflow were so different that it had a negative effect. And when I'm making rounds to see some of this in action. I also had the question of, well, why are you collecting these data, and why are you doing it with this frequency? Sometimes it was a very reasoned response, and it was a practice standard. In other cases, it was because, well, that's how you do it. So again, use your critical thinking in your workflows and your design of your data to be able to make that efficient and effective. And then obviously what support is required to be able to implement best practice. What are some of the challenges? I think one that we all deal with is that you're in a constant state of implementing something new, even if you have your major enterprise EHR implemented. There is always the next version and the next application that you're adding to the suite, if you will. So you're supporting ongoing implementation and a growing clinical user base, but we want to focus on the clinical quality structure and the outcomes from the system. So it takes user support, workflow assessment, reporting, system alignment, and building evidence-based practice. So all of those areas need to be thought about in a strategic way and resourced to be able to deliver, so that you don't end up with, if you will, a model of imbalance. How do you demonstrate value? From an internal systems perspective, aligning key stakeholders, establishing metrics, making direct links from your corporate safety and quality strategic objectives, and leveraging your system capabilities for reporting, analytics, and workflow. Very, very key. Also, the value comes through being able to link with external partners. So there are macro system partnerships, community partnerships, academic education research, corporate user groups, and that includes both our partnerships with our HIT vendor colleagues, but then there are other types of user groups as well, and professional and policy associations. These are limited lists, but you get the idea. So how do you target and demonstrate the value? I think that an additional challenge is the game changers that are always before us. So I've listed some here: individualized, personalized medicine, the analysis of the genome and making that available has transformed, not with the rapidity that was initially thought, but certainly transforming not only the care and the design of care and targeted care to genomic genetic profiles, but think of the data and the size of the databases in healthcare that would be required to manage genetic data for every patient in your system. It's pretty astronomical. I didn't bring the figures today, and I don't have them in my head, but you can easily find these in the literature of the extrapolation of what the data burden on a country, on an organization, on a practice will be with that kind of level of detail. Business intelligence, also a term that's bandied about a great deal. I define business intelligence as business and clinical intelligence from a strategy that's more local. It's within your own environment, whether that's a hospital or a system. And big data, I define as it's the aggregation of multiple data sets from multiple sources and your data are a part of that, and predictive analytics work on that. It's a very different analytical model from business intelligence. Our changing policy environment, accountable care organizations, value-based purchasing, other models. We're in the middle of the transition, and health information technology both affects that and is affected by it. So the movement to population health, 5 years ago, it was talked about. Now you can't talk to a health system and not hear the terms population health with some metrics behind them. Social networking and consumer pressures, huge area of interest to you might be, if you may be involved in this, the Mayo Clinic has launched a social media institute for healthcare, and it's the use of social media in healthcare. And they have a training program that they put out, very, very interesting reach and transformative to what can happen in the organization. Consumer involvement in EHRs and personal health records and consumer engagement and activation. As you all know, we're somewhat driven by this from meaningful use standards and making sure that we can measure how much our patients and families are involved in care. However, this is a powerhouse that is untapped. And learning from patients and families and the community what it is that's meaningful to them and how they might be involved in their care in a different way and how they might be involved in the use of technology is right before us. I'm sure that you have seen that there are some studies where and some organizations that admit patients to the facility, the patient's handed an iPad, and that communication with their caregivers ensues from that point of, or with the family and the caregivers from the time of their admission. So the wearable devices I did not put on here. It's another just looming there. What are we going to do with the data? How are we going to deal with the data in the healthcare organization? I'll leave you to solve that, but it's a very large area of impact. So in summary, using systems in meaningful ways to build clinical practice knowledge and useful outcomes is a huge challenge. It is one of the most engaging pieces of work I think that you can be involved in. It's extremely exciting. It's dynamic. It is never dull, and it's about knowledge. Those of you who are captured by research and say, I want to do this study or I want to participate in this because of the spirit of inquiry and understanding, I would offer to you that you also can have that same spirit of inquiry around health information technology systems. What does it mean? What's the so what of having put in all of the clinical system and all the work that you've done? What difference does it make, and how can we demonstrate that? What can we learn about what really happened with this treatment methodology in the real population, not in the research population? And then how can that inform our practice? And we feed that back into the system again. Aligning clinical informatics roles on parity with your organization's leadership structure. Just very, very important that these are integral clinicians and technologists and need to be integrated in the governance structure. And then, are we on a journey in transformation? And are we learning a learning organization? What does that mean? You have to continue to use governance effectively. It's a real challenge. Who owns the system? The clinicians. The point of care systems are owned by the clinicians. So how do we make that real and bring their governance, if you will, and wisdom within our systems to be able then to apply across an organization? We want to be able to apply evidence to practice, from practice, support ongoing adoption and optimization, not just use, and then to be able to measure, evaluate, and communicate the outcomes to others. So, thank you very much, and I look forward to further discussion.
Thank you, Dr. Frank. As you all know, I have no biases. I always felt over the years that Dr. Frank got it about health systems, about communicating nursing knowledge, and I think today she reinforced that she is of the real world and is very, very committed to making sure that this works for all of nursing and the bottom line, to improve the care of children and families. One of her many comments I thought was very striking, and this is, I think, a real challenge, and maybe I would like the Bear Institute, to take it on to show the world. And that was the ability to tell a story of patients and families in the EHR. I think this is what nurses often feel like, where's our data? And why you just talked about our descriptive data, where is that in the system? But I would like to see children's take on this leadership of the ability to tell the story of patients and families in the EHR and make it a clinician and Bear Institute outcome. No, again, I have no biases. Our panel today are leaders within our institution and this integration of electronic health records information technology. First panel member is Linda Talley, our Vice President and Chief Nursing Officer. And some of you may not remember or know that she has had leadership roles in health information technology at Children's over the years. She was co-chair of the Clinical Oversight Committee with the Chief Medical Information Officer to support organization-wide and IT strategic vision. As Director of Nursing Systems in the Neonatal Services, she guided the development, implementation, support, maintenance, and enhancements of clinical information systems as they relate to nursing and patient services. She also saw the successful implementation very early on, what was then called Phase 2, of the Clinical Transformation Initiative, which way back when was physician and nursing documentation, emergency department documentation, do we ever forget CPOEs, surgical tracking, scheduling, and enhancement, and then we call them medical records and not our electronic health system. She has received certification through the Wharton School University in the Wharton Nursing Leadership Program. And as many of you know, she was also the principal investigator of a funded PICU research study to understand factors associated with monitor alarm generation in critically ill children. Again, the use of data and the interpretation of data that she will bring to this conversation. Camille Nair leads the Bear Institute Innovation Group to create new innovative solutions to improve pediatric healthcare outcomes. He has led several innovation and implementation projects, including an innovation engagement at the first Cerner IT Works in Naples, Florida. It seemed like you move all over when I read your bio. He was involved in the early implementation of Cerner care management at various sites around the country. And as a graduate student, he performed a patient flow pattern study at Children's Healthcare in Atlanta. And we all know he found bottlenecks and problems and challenges, and he defined the metrics to address these challenges. He states his favorite project in the new Innovation Center and the solutions coming from it and the collaboration with nursing research and quality outcomes. And I think that's a real advantage of the Bear Institute, if you haven't been there, of the proximity. You look over your little workstation and there's all the Bear Institute Health IT folks. And it's really a phenomenal opportunity, I think, for all of Children's to advance in this area. He said the favorite part of working at Children's is seeing the impact of the kids and how we touch their lives. A side note, and I forgot, I didn't have time to look this up. He speaks the only palindrome language in the world, which is Malayan Alam. He'll correct it when he comes up. Dr. Cindy Rwandawa is our third panelist. She is the Director of Clinical Information Systems and Professional Development. She leads the Departments of Nursing Education, Professional Development, and Nursing Systems, which includes our board-related visitors-sponsored simulation program and nursing informatics. She partners with all patient care areas to advance professional development for all nursing staff. In collaboration with the Bear Institute, she leads the implementation, integration, and optimization of IT solutions that impact clinical nursing practice and operations. And I also commend her. I've enjoyed over the years having chats with her in her vision into the implementation of the RN Connect, which is a very significant initiative to improve communication and access to resources anytime, anywhere for all nurses with children. So if you welcome our panel. And it's my understanding that they have chatted and determined their order of responses and questions to Dr. Frank.
Yeah. Okay. Thank you so much, Suzanne. And thank you, Barbara, for your presentation. It just hit so many points home for us. So we had a little bit of a mini rehearsal yesterday to kind of plan out our talking points, and our assignment was to take good notes during your presentation and think of one or two things that we wanted to highlight. And I think I just counted 8 pages of notes. So I don't think I'll take the entire time committed to the panel discussion if I go over all of my notes. I think just take that as evidence to say that the timing of your presentation couldn't be any better in terms of where we are as an organization, and specifically where nursing is as it relates to our relationship with the Bayer Institute and a heavy, heavy implementation of technology that's taken place over the course of the past year and a half. And really, I think we're a little bit at a pause right now where we're thinking about all of the new tools that we have in hand and how we're going to make practical sense of that. So I just, some of the things that you mentioned today that really resonated for me was the challenge of being able to get evidence from the EMR that we put a whole lot of evidence into, and now how are we going to extract that to make meaningful use. I so appreciated your comments about the need to have optimization take time out, and I think that, we just had a meeting on Tuesday, I believe it was, with actually the whole week, but I had a one-on-one with the CNOs from Cerner to talk about exactly the need to take a pause, if you will, and a deep dive into optimization to begin to think about where we are now and how we might be able to improve. I had an interesting conversation with someone over at GW earlier this week, and they shared with me that they have made a decision they are Cerner clients, but they've made a decision to move, at least for ambulatory, over to Epic. And I think about the disruption that causes, the heavy, heavy investment of resources that it takes to really shift gears there. And I have to wonder whether or not a piece that's missing for them is the piece that we're talking about now as an organization and that you highlighted. So, it's kind of the so what after this heavy implementation. Where is the infrastructure to support and to begin to hardwire that the implementation, although ask anybody in this room or any of us who've gone through it in the past year and a half, although was intense, the real intensity is now. And really to kind of shift gears was kind of startling for me, and I couldn't help but think for their organization that maybe that's a piece that might be missing. I really wanted to thank you for bringing up the piece about thinking about the folks who are behind the scenes, staring at screens all night long, helping to support us, what a critical role they play and how meaningful it is for them when they do step out to the units or really have a just-in-time moment to think about the impact that it has on the care that we're providing at the bedside. I could go on and on. One thing that I did want to mention that I want to thank the Department of Nursing Research and Quality Outcomes for making this entire day possible. When I was thinking about, the past year, and if I were to summarize some of the headlines that we've enjoyed over the past year here at Children's from a Nursing Research and Quality Outcomes perspective, the headlines would read something like this. Children's National Nurses had their first ever podium presentation at the National Magnet Conference, and it highlighted nursing research. This specifically the work that Beth Harkness has been leading around genomic projects, and what a moment that was, our first ever podium presentation in highlighting nursing research. Another very significant headline, Nursing Research at Children's National had their first ever invitation to a foundation event in Palm Beach in Palm Beach, Florida, where Dr. Pam Hines and Dr. Vicki Friedenberg were highlighted to philanthropists to talk about nursing research at Children's National. Again, a first ever opportunity. Children's National named their first ever endowed chair to nursing research. Of course, we know that is Dr. Pam Hines. Children's National celebrated Dr. Suzanne Feedham and her recognition through the Fellowship of the American Academy of Nursing as a living legend. And today, Children's National welcomes back Dr. Barbara Frink welcomes you home, as you'd like to say, to talk to us again and to inspire us with her work as it relates to nursing informatics. Again, a topic that's very, 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 very near and dear to us. So I've taken up 8 pages of thoughts and summary, and again, I just want to thank everybody very much for being here today, and I'll pass it over to Simi.
Thank you. Good morning, everybody. Thank you, Dr. Frink. I think your presentation was wonderful, and most striking to me is it affirmed where we are, as Linda said, in terms of our journey since I've been involved with the Bayer Institute and with nursing informatics for about the last 18 months in my role. And Nellie Robinson, our previous CNO, used to always say quality research and education. And so as I listened to your presentation, I put my educator's hat on and thought through, in addition to some of the very key points you made about an integrated system. Dr. Feedham mentioned, how do you tell the story? As you know, on Wednesday when you were here, we spoke about that. The idea and the need for making sure that at a micro and a macro level, we're really understanding the continuum of care and the impact of the integration of EHR, other IT solutions, mobile devices, device integration, and the opportunities that really exist for ongoing improvement and realizing the value of not just strategy and infrastructure and partnership, but the continuous cyclical process that's really important. From my educator's hat, I think about the students. As an organization, Children's is an academic environment, medical students, nursing students. In addition to the work that we do to provide care for our patients and families, we're also consistently teaching, and how do we engage them in this process as well, and how are they involved? So we truly are a learning organization from every aspect, and that they are being prepared to be digital citizens and to really care in the 21st century. And so you really opened my eyes up to the forward momentum we need, the journey that we're going to be on that's not going to stop, and the value propositions that we have to make from the aspect of every person that we interact with, and truly the need for strategic relationships. So thank you.
Oh, thanks, Simi. Oh, thank you. First of all, I want to thank for the opportunity. I work for Cerner, and moving to DC and working with Children's National has opened an entirely new way of looking at things. I was just telling Linda that I don't think I would go back anywhere else. I think I really appreciated the relevance of your presentation at this point in time where we are in the history of medical informatics. It was very relevant, so thank you for that. My particular thought as a health information technology technologist is really around the knowledge management and how can we really move the meter while facing all these daily pressures of how we practice care. 2 key points around that. If you look at the impact of health information technology, the folks who have the maximum impact are the patients and their families. But those are they are not primary impacts, they are secondary impacts. But the real impact is actually on nursing the most. If we actually really look at the total continuum of care and see the HIT impact. But there are some things which we as thought leaders in this industry have to really start thinking about. It's really about how we create validated learning environments. How can we validate what we have learned so far and put it into practice? And I think the biggest issue, especially on your one of your slides where you showed the cycle, where you really focus on implementation and not really on the outcomes. The problem really is that we are not intentional and we are not, as organizations, really clear about what we want to achieve. Not just our focus is really on operationalizing rather than driving value and outcomes. So when we think about value, there are two key points there. One is speed to value. You can have value over 20 years, but that's not the point of implementing systems, right? We want to drive value as soon as we can. So speed to value is a very important topic, and really creating leverageable intellectual property, especially around care patterns and models. The reason why I say that it's going to be very relevant in the ACO environment, especially research organizations like Children's National, Mayo, their core competency is going to shift towards creating leverageable IP, whether it be in nursing outcomes research or providing care. We really, as industry leaders, need to think about that. Other than that, I work for a health IT company, but at the same time, I'm seeing how we are in the constant mode of implementing. It's good and bad at the same time. We have to do it because it's like friction. It's a necessary evil. In order to move the meter, you have to implement. But being intentional is what I would urge us as organizations to take back. How can we become intentional? Thank you for your morning time. It was really nice having you here. Thank you.
Would you like to respond or ask, and then we'll open it up for questions.
Well, I appreciate each of your perspectives. Thank you. I hope that you can sense that we're in a community here, and it wouldn't matter if you were in California and I was coming from the East Coast, because these themes are absolutely dominant across the country, and it's not just an system by system, but all of us together of how can we move this along by working together. So I think your comments, I love the headline approach. That's very positive, and I think a really good communication strategy. I'm putting that down. So in regard to education, and I pretty much completely left that out of my commentary, and your points are extremely well taken. I was talking to Heather this morning, who I met at the coffee hour. Is she here?
He is here.
Yeah.
There she is.
Heather. So who was telling me about her study work with putting the residents and nursing teams together, and how much it changed the communication. We're behind you. We're going to be coming along, and I'm going to be knocking on the door because of the care-aware phones, communication system, and understanding what the texting between clinicians is going to do within the environment. So I was very intrigued with this program, which evidently, after an initial inoculation, if you will, had a long-term effect of throughout a residency program, the communication increased between the caregivers and the residents. But lots of challenges there. We also have run a program of 1,000 residents, and I know we have diverse practices, and I am sure challenged by those same issues, and we have not answered those questions. So thank you for putting that forward. And then, Peel, your comments about intentionality, I think, are extremely, it's a profound concept, right? It's not just strategy, it's thoughtful strategy, and it's taking time out to think about it. One comment I didn't make that I had been thinking about was that it's very hard in our healthcare delivery systems with so many, the tyranny of the urgent, right? It's an urgent environment, and we have to respond quickly. There are critically ill people and families in huge distress and communities in distress. How do we do that? Be intentional and thoughtful. And so one of the concepts is to be able to identify what are the most important areas, because this is a field where you could pick a plethora of items, and if there are so many different interest groups that are working in their own arena. That's very positive in terms of engagement, but it doesn't really allow you to glean really profound results because it's too diverse an effort. So picking some real highlights of where are you going to see, where are the most critical questions? What do you need to answer? And work on those and get those resourced and then populate out. So those would be some thoughts. Thank you for your comments.
Thank you all. Are there questions for Dr. Frink or the panel?
Thank you very much, Dr. Frink, for your presentation. It was so just heartwarming to see that there is that thoughtfulness. Because my question for you is, and as we move forward and we talk about these unintended consequences that we implement, and we are implementing at a rapid rate, do you have any best practices as far as post-implementation that you have found that you can really get that information that you're getting, that you spoke to about when you talk to people afterwards and go and make rounds? Have you established some practices around that and some recommendations?
So I would say both yes and no. Do I think that I hear the voice of the majority of clinicians? No. There is huge room there. There are communication challenges both from my perspective of how do I reach the 8,400 nurses in a consistent, with a consistent message. I mean, there's normal publication channels, but we all know it's the relationships that matter. The other, so that's one thing, and that will always be a challenge and more work to be done in that area. Some things that we have done at MedStar that are seem to be bearing some fruition is to establish a governance structure post-implementation that is user-based so that every single organization, if they have any changes in optimization, that goes up through the clinical. We have a clinical informatics director, nursing informatics director, and staff in each hospital, and a CMIO, at least part-time, in each hospital from that arena. And then they take those change requests, and then we have established by application, if you will. So if you're familiar with the Cerner E's here, if you'll excuse me for that, but the FirstNet application, the ED system, the SurgiNet application, and the CareNet application. And we have the user groups there that are ongoing working groups every week that are debating the issues. Then we have what we call functional working groups, which are we've established in respiratory therapy and nutrition, in speech, and in occupational therapy and pharmacy. So lab is organized slightly differently, but they still feed into that feedback system. So people are working on their own disciplines or practice areas, and then they communicate with one another. So there's actually a trail, if you will, of vetting for a request to try to get at that issue of the unintended consequence. So if I have a FirstNet group making a unitary decision about something, you know it's going to impact the admission and what happened right on the clinical unit or what happened in the community. So the governance structure has assisted with that, and it seems to work pretty well, and there is a lot of good dialogue back and forth, debate. Then those requests come up to an executive committee, and then there's a governance above that, and that's made up of all the directors, CMIOs, the CMIO and myself, and the lead analysts, the program managers there. And then we have a structure of an interdisciplinary all hospitals in the system and ambulatory practices. We're in a group called Clinic, which is the Clinical Informatics Council Committee, and we meet about every month to 6 weeks for issues of policy and practice that would be system-wide. And then that group reports up to the highest governance of the system in practice, which is the CNO Council, and Vice President for Medical Affairs Council, which is a joint council. So there's that structure. The other piece that I put in place is that I meet every week with all of the nursing informatics staff across the system by phone in an hour's call, and it's an open call. They and I drive the agenda, and then we invite people, pharmacy, whatever, the relevant discipline to come and talk about any particular issues. And then I meet weekly with the CNOs across our system in the hospital, so the 10 CNOs, and I meet on a call every Friday, and it's called the CNO Informatics Call. And what this does is so much of informatics is so pressing, right? And we've got a problem, and it's with the Pyxis machines, and it's now, and it has all of this implication for the point of care. So it would, in some cases, dominate the discussion that happens in the CNO Council or your top nurse executive leadership council. So if you siphon it off, it works a little better, and you can deal with the practice issues and the administrative executive leadership, and then have a concentrated period of time to deal with informatics.
Mm-hmm.
So what we're hearing is transparency and integration and interaction across all systems. We have time for one more quick question. Ann?
I just had a video
It's
on. My question is, okay.
Hello? Okay.
Yeah.
I just want to kind of follow up on what Kathy said, and I'm very excited to hear that as an organization we're thinking about optimization in a much more thoughtful way, and the where I see the intentionality coming in, because we don't know what the unintended consequences are going to be of all of these innovations, and so the intention and the thoughtfulness needs to be about how we're going to continually go back and evaluate and optimize the systems. That's, to me, sort of the biggest problem that we've gotten ourselves into with all of this technology, is that we don't, I extract data from Cerner, and the need for optimization of just our basic tool as opposed to adding new tools it seems to me so important. So it was exciting to hear that we're going to, sort of, it's almost like the direction needs to go the other way, not developing the tool first, but sort of developing how we're going to use the tool, or all the people that for all the people that are going to need to use it.
Thank you.
Thank you.
Just a comment on that. If you actually go to the west side of this country, on the startup space, there's this whole concept about all these. Every year there are about 100 startups coming out, right? What they do actually is very interesting, which we could as healthcare organizations learn. They will start with a very minimum product. It's called a minimally viable product, and then they will actually ship it to a subset of users. And then the users give continuous feedback, and then that feedback creates a product which is much different from where they thought the product would be. I think what I'm just trying to say is that there is an industry notion moving on, at least in the startup space, which is actually doing this in very great detail. That thought process has to be emulated back into healthcare. So it's very well taken.
Mm-hmm.
I look to Eileen to make sure there are anything we've missed or announcements that should be made?
Just have a couple minutes for transition.
You're welcome to stay with us for the rest of the day. CEUs are being provided throughout the day. And again, we thank you all for joining us. And Dr. Frink will be around for a while, and I'm sure would take other questions and challenges you may have. Thank you.
life